Tēnā koutou, it's lovely to be here, and thank you very much to the Office of the Privacy Commissioner for not only for supporting these really important research projects, but also for putting on this day, because as researchers you don't always have good connections with people who are working in your field, funnily enough. And we can sometimes get stuck in our discipline and not look beyond it. And so it's been lovely for me to hear the presentations this morning. My son recently reminded me of a concept that I'd forgotten, which is tessellation. And I was thinking about tessellation this morning because the projects that we've presented, they tessellate well. They sit alongside each other very beautifully, I think, to make something that looks more like a complete whole. So, as Paul said, I'm an ethical theorist. Well, maybe Paul didn't say that, actually.
No.
I might be putting words into your mouth. He said my name or a variation thereof. And I'm going to add to that the piece of information that I'm an ethical theorist. So I don't take notes about patients myself, but it strikes me, and it struck Isobel, who's been my master's student, we've been working together with Katharine, that there were a whole lot of interesting ethical issues around notes. And so, as has already been discussed this morning, there are complex issues, both practically and also legally, but alongside that, philosophically, relating to privacy. So the concept of privacy is sort of what we might call an essentially contested concept. So what its boundaries are uncertain, why it's important is contested, and what constitutes breaches. That's also an issue which is highly debated. So there's a big literature actually in philosophy about the concept of privacy. And then there's a big practical literature about threats to privacy. And that literature is particularly, I guess, live and large in medical practice because of the inherent sensitivities around healthcare records. And as has been noted already this morning, a lot of the concern is about inappropriate access to notes. So I think that there's a good level of acceptance that notes need to be taken. And then there's a question about who gets access to those notes. And this has already been noted too, as technology changes, and that has an impact on how easy notes are to distribute amongst a team of workers, then the complexities also, respond to that, so that they change, and the potential solutions that we might need change as well. So there's issues around legitimate, illegitimate access. But what interested us were slightly less contested or obvious issues, which have to do with what happens in a healthcare interaction, or any kind of care interaction involving social agencies. So if you see a practitioner, it might be a nurse, as has been discussed by Jill and Leonie. You have an interaction with a person, and you exchange things with that person. And because of what we're like as humans, we can sometimes overshare. We can put in personal details that we might not put in if we were writing a letter to the person. But we're not writing a letter to them. They're there, we're talking to them, we're exchanging information, and that information is freely given by us. And so in one way it doesn't seem to raise privacy issues because we've shared it. But the exchange, it's not like the exchange between, friends over a cup of tea, or, your neighbours over fish and chips. It's with a professional whose interaction is directed at a professional purpose. So the professional has these obligations, and the client knows that they have obligations. They know that things are being recorded. But but what is being recorded? I don't know whether any of you have asked this question of yourself when you're in a clinical interaction. I recently was in an interaction with a doctor, and it was over strep throat, my daughter having strep throat, and the doctor didn't want to give her antibiotics, but after her third positive test of strep throat, I really wanted her to have antibiotics, and all the other kids were getting it, and why couldn't my child get it? And I started to get, like a bit of a kind of middle class kind of panic on. And I felt really worried, actually, about what the doctor was recording about me, because it's all about me, kind of a little bit of narcissism maybe was happening there in my thinking. I wondered whether they were recording that I was like a drug-seeking middle-class mother, and I didn't want to be represented in that way in the notes. Now, this interaction occurred after we started this topic, but it represents the sort of phenomenon that we were interested in exploring, which is not about who gets to access the notes. It accepts that there are legitimate accesses, but it starts from the premise that even legitimate recording and legitimate access raise ethical issues. It's not like there aren't ethical issues as long as our notes are accessed legitimately. There are issues about what can be recorded and how it can be recorded and what that means for the person, and whether privacy is a kind of a concept that's valid here, whether it has something to do with privacy, because it seemed to me like the concerns that make privacy important to do with being able to control the way that you project your identity to others, to do with your personal welfare interests, that those things also have a role in or are relevant to questions about how you are recorded. So we were particularly interested in how things like opinions, impressions, suspicions, hearsay, so things that have been told to you by someone else about your client, things that your client has told you about someone else, how those things are documented in the record. And we were interested in whether practitioners experience these decisions as ethically problematic, and if so, how so? What were the natures of the ethical worries that they had? And we were interested to see if there were any principles that were at play in their reasoning about this, and whether we could use those principles and kind of develop them with philosophical analysis into a set of principles that might inform these difficult decisions in a kind of more systematic way. So what we did is we chose an area of practice that seemed especially rich in these kinds of problems, and that was social work. So social workers who are members of a healthcare team. And there are a number of different settings, and Isobel will explain those, where social workers are part of a team with other professionals. And those other professionals may have different remits and maybe different informational needs. So they may not need such kind of rich and sensitive information as the information that social workers come by. And we drew on empirical work to inform an ethical analysis, and what we've done is, I think it's quite good, really, quite good. And Isobel has written her whole thesis, and she got an awesome mark for that thesis. That thesis is up on the Office of the Privacy Commission's website, I believe, and we may have to have a little chat about that, actually. And that raises potential issues for the papers that we're publishing, so we might have to just take that down for a little bit. But Isobel will be very happy to share the summary of the results and what we did. So I'll hand over to her.
Great, thank you so much, Monique, for that wonderful introduction to the whole spectrum of issues that we attempted to cover in this one-year project. It sounds massive, and it was massive as well. And I think we're ultimately still working through a lot of the fascinating questions that it raises. All right, great, slides are working. So as Monique pointed out before, what we focused on in this project was the fact that health practitioners of all kinds are required to make judgments when they record. And we were particularly interested in the kinds of information that they would record that could be particularly sensitive or stigmatizing. So we're not necessarily thinking about details to do with my asthma or whatever, but maybe details to do with my intimate relationships or with my mental health or with my parents or anything like that. And so that's why we chose to focus on health social workers, because we knew that they would come into a lot of this kind of information. They also do home visits, of course, so they encounter details of people's lives that they haven't even deliberately told them, but they can pick up from the environment. So the main research question that we sought to answer was what concerns they might have about recording this kind of information in records that they share with other people. And health social workers work in teams with others. They're sharing notes with doctors, with nurses, with other social workers, with other kinds of allied health professionals like physiotherapists. Did they have any concerns about recording in an area that could be seen by everyone? And how would they like them to be resolved? So the methodology was that I'm not a clinician at all. No one has allowed me to go near a patient ever, which is a shame. And I'm also not a lawyer, just as another disclaimer. So if you're concerned about any of the legal implications, please see my supervisors. And some of the work that I presented here might seem a little bit obvious to clinicians, like you might know it already, but we didn't know it. I certainly didn't know it. And I was fascinated in analysing the issues of recording from an ethical perspective, but also what was fascinating was how little empirical evidence there was at all about recording, about what kinds of things people recorded, how they made judgments about recording, even exactly what notes were kept in any particular DHB and who could see them and all that kind of thing. So that was what we aimed to find out. We adopted an empirical ethics kind of paradigm based on the philosophical tradition of pragmatism. And pragmatism establishes that ethics and practice aren't entirely separate, and also that philosophy should have a kind of practical approach to real life, that it should be performing some use. So we hoped to do some useful philosophy here. So it included a literature review and a study of privacy and confidentiality and those kinds of issues, as well as qualitative interviews with health social workers. I talked to 11 health social workers for an hour about their recording practices, their ethical concerns, and their judgments. I analysed the interviews using thematic analysis. So the interviews were semi-structured, where I really tried to elicit accounts from people about what their ethical concerns were and the reasoning behind those, and how they might seek to resolve them in their own practice. The interviewees were based in 3 different regions across the North Island in organisations that will remain anonymous. 4 had roles associated with mental health care. 2 worked with older persons, 2 in oncology or cancer, 2 had general hospital-based roles, and 1 worked in primary care. They had a range of ages from late 20s to early 60s, 1 male and 10 female. In the interviews, I focused on 4 major topic areas, and I'll use those now to talk about the results. So the first thing that I wanted to talk to social workers about, it was a good introduction to the interview as well, to just ask them about their practice, what notes they kept, and who they shared them with, and a little bit about what the function of their notes were as well. So all of my participants reported that they kept notes in various different places. Any one participant was recording in more than one place. And these notes were shared with a variety of people, both in their team and in their wider organisation. So that could be in the DHB. Some of these records were in hard copy and some were electronic, so any one participant was likely to be recording in both hard copy notes and electronic notes. So there was some duplication as well. The documents that social workers shared with others would include initial assessment documents, inpatient progress notes, community progress notes, referrals, risk management plans, and also emails, which do count as a record, and several participants mentioned were very useful as a form of recording. So these documents, some of them were more likely to be seen by others, and others were less likely to be seen by others, but they were all accessible to everyone. So that was an interesting feature. There was no real shared record separate from other records. If it was a health record, it could be shared. Whether it was accessed was another question. On the whole, participants were very supportive of sharing their notes with other people. And they didn't feel that this contravened the confidentiality they had with the client. In fact, they could be frustrated when their notes weren't read or accessed by others. Outside the team, they might be more careful about sharing information, and they'd seek explicit client permission, and this would include sharing information with GPs. One participant I talked to, and only one, kept a separate record from the general health record. So here's a quote from her. The record that she kept that was separate had been set in place by her predecessor when she reached the organisation. So she hadn't made the decision to set this up. She had followed through because she thought it was a good system, and she used that separate record to record both practical details that she felt were more complete than the other health carers needed to know, as well as sort of slightly more sensitive information about their family background or that kind of thing. But she would make sure to include relevant information in what could be seen by everybody. So one of the interesting things that we wanted to know was exactly what was left out of records. Were there any deliberate attempts to leave things out? And leaving out the details was something that participants talked about quite a lot. It was a common strategy for ensuring that what was recorded was both useful to others and that it protected the client's privacy. The kinds of details that they discussed leaving out were often things about details of past trauma or abuse, someone's detailed expression about their emotional state, like how they felt about themselves or their self-esteem, family conflict details or discussion of finances. One of the interviewees referred to this as the dirty laundry, saying that they didn't, clients didn't want their dirty laundry to be aired in the record for everyone to view. Luckily, providing a summary of this information that included what was important and needed was a good strategy for dealing with leaving some of this out. And this has important practical implications because an unwieldy and irrelevant record is a burden for other clinicians and risks obscuring important information or putting them off reading it entirely. One said, "No one wants to read an essay." Yet they would record sensitive information, such as these details, if they were thought to have an important relevance to the client's healthcare. So here's interviewee 7 saying, "You can put things about people, that information, without being too detailed. Like I will say, when there's a conflictual family, there appears to be pre-existing conflicts in the family. Full stop, leave it there. So the next person will go, oh, okay, the family don't get on. But you haven't said what's gone on unless it's actually relevant to what you need to be doing." So the reasons that they might leave out details were sometimes a little bit hazy, but there was a general feeling that once something was written down, the security of the record couldn't be entirely guaranteed. And they weren't thinking there about hacking necessarily, or even data breaches. They were particularly thinking about family members being able to access the record, either legitimately because they could request it, and some of the participants, including myself, were a little bit wavy about whether or not they're able to get hold of it. But they were worried about them being able to read it, but also about them just coming across information. For example, in a referral letter that gets sent to the house and the mother reads it when it's actually about the son. So there's a concern there. But there's also a concern about how other health professionals might treat that information. Those kinds of details might colour the relationship they have with the person before they meet them. And this could somehow, this wasn't something they wanted to be responsible for. Interviewee 6 said, the concern could be that they bring it up with the patient or it changes the judgment of that patient, which in theory, of course, should not impact anyone's professional care, but we're human as well. I guess it's about not wanting to impact on the overall picture too much. So there was a feeling there that to put too much information in the record was to expose clients and to not show them proper respect. As Monique has mentioned, one of the things we were particularly interested in was whether or not social workers would record their professional opinions or impressions. And this sort of relates to what kind of information is suitable to be recorded. Yet this was an easy question for my participants. They all stated that they would record their impressions, although they are very careful to distinguish them in the record from what could be considered factual. In fact, sometimes recording their impressions or their opinions was the most accurate way to record because information was unreliable. They didn't know necessarily that they could... Clients would be saying things, and they might either be an older person and getting into the first stages of dementia, or they might be saying things that were deliberately not true, or they also might just be their own perspective. They were giving details about someone else that was their opinion themselves. So in some ways, for social workers to say my opinion is or my impression is the most straightforward way to reflect that in the record. Being really careful to distinguish what was your impression, though, was important because social workers are legally accountable for what they claim to be the truth and what they say to be their opinion. But it was also important for ensuring the record couldn't be misinterpreted by future carers, and they wouldn't read it and think, oh, this is the case, and then start going about their care when it wasn't the case at all. So it was important for ensuring good health care for the client in the future. But also ownership of these opinions prevented the record being compromised by pejorative judgments about a client that could be misrepresented as the truth. So there was a real attention to language and the kinds of ways that a client was talked about. Using judgmental language could encourage or permit outward prejudice against the client. This was prejudice that participants considered significant and material. And the bias that was ultimately unfair, unprofessional, and could compromise the care for the client. Records should be recorded as if clients could read them, which is of course the case. People can access their records. But this was also something that participants described as a positive for their recording. They wanted to do this regardless of whether someone actually accessed them. Here's interviewee 9 saying that she has read clinical notes that have been recorded in a way that makes her cringe because of implied judgments. I can't control how other colleagues choose to record. What I can make sure is that what I record is accurate and reflects. And if it is opinion and not a fact. So finally, I discussed with my participants how they felt their clients approached their records, whether or not they received a lot of client requests to view their records, whether they had clients who were worried about what was written about them or asked particularly for things not to be recorded or not to be passed on. And this wasn't really the case. All participants, for a start, they all described they would talk about the idea of team confidentiality at the beginning of their clinical relationship. So they established that what a client told them wouldn't necessarily stay with them, but it was confidential to the team as a whole. And they reflected that this was a concept that clients were pretty much happy with. Clients hardly ever made requests for things not to be recorded in the record or shared. There were very unusual instances. They also hardly ever made requests to see their records. Several participants described recording together with clients, either recording in front of them or asking for input about what they'd like to be recorded. Although one participant mentioned that although she'd like to do this, there just isn't time in the clinical encounter. There's a lot more stuff to talk about and the records aren't really forefront in her clients' minds. Participants also overwhelmingly expressed that they did not get the sense that clients were reluctant to disclose things because they thought they might be recorded. In fact, some of them said that they got more information than they needed. Interviewee 5 said, "I'm surprised by what people tell me some days." So there was a definite feeling there that clients were happy to share information because they saw that it would benefit them. They wanted the support that could be offered. Though they might hold back things in the cases where they thought it might contravene their interests. For example, an older person who's worried about being put into a home, who holds back information about how they're not coping by themselves. But that wasn't necessarily about it being recorded. It was about their general interests. Even interviewee 4, and she worked in mental health care with a sort of long-term kind of care provider. I feel if someone's meeting you for the first time, they just want to tell you what's been happening. So they're not really caught up in that detail of, do I want everyone to know or do I not? So that information was disclosed by clients and recorded with their permission is an important element of the moral license to record and share it. And it seems from what participants told me that clients are happy to disclose information in line with their interest in healthcare. Although they might not give explicit permission for each instance of recording, their overall engagement in the health encounter indicates their tacit consent, that they support the sharing of information necessary to support their health. So those were the results of our interviews, as much as you can get results from interviews. These are some principles that we developed from what participants told us. First, the social workers are aware when they record that the record that they use will be used to make judgments about the care of the client in the future, judgments that should be made appropriately. So information should be recorded if it is necessary to the shared purpose of healthcare and in such a way that it is accurate and neutral. So what it means to be necessary to the shared purpose is to be, loosely speaking, relevant to health. Participants spoke about relevance to health being a key reason for recording information, even if that information has a personal or emotional component. The judgment of relevance is important in one sense because the record has a limited bandwidth that shouldn't be taken up with details that are not needed by other practitioners. And so selection of what it is important for other carers to know is a way of maintaining a high standard of care. Sifting of a wide spectrum of information, such that social workers get, for what makes a difference to the care provided and what doesn't, could be argued to be part of the clinical role of the social worker. That's what they have experienced and that's what they're there to do. Recording and sharing what is necessary for healthcare is consistent with what clients expect from that context. They know they're involved in a healthcare context, they know they're giving up information, but they expect it to be used for their health and not for other reasons. While clients might not display concerns relating to their records or worry about dispensing with private information in their settings, they're happy to relinquish it because they know it serves a purpose for them to advance their interests in getting good care. And this is a purpose that social workers share. They also want the client to get good care. So those are the first two principles, that it be necessary to health and that it be a shared purpose. The next two are that it's information is recorded in a way that is accurate and neutral. As I've mentioned, being accurate in the social work setting can be difficult when some things are unclear and somewhat unreliable. So being accurate refers to paying attention to and recording the epistemic status of information, whether it's an opinion, whether it's a report, or whether it's more factual than that. So using language is important in reflecting what the case is and what the case isn't. For example, I talked with participants about their use of the word hoarder for someone who had a lot of things in their house. And they were not comfortable with using that word unless there was some kind of mental health diagnosis that could back up someone being a hoarder. It makes them accountable then for a kind of mental health diagnosis themselves if they just use that word randomly out of the blue. So a close attention to unbiased language also avoids the kind of inherent judgment in notes that can prejudice the worth or dignity of a client. Recording accurately and neutrally shows respect to the client as an independently valuable person, and it also supports their right to impartial healthcare by not prejudicing future carers against them. All right. So here are some brief conclusions for a brief presentation on a large project. The principles I've talked about here reflect certain virtues of the social work profession and are a reminder that recording cannot be separated from wider professional practice. The kinds of concerns that social workers have about records are about being a caring social worker, being trustworthy, showing proper respect, and also ensuring that there is impartial access to healthcare. These principles can't solve every tension about records, and some moral residue remains. I haven't had time to go here into the particular cases that social workers raised where they felt very, very conflicted about what to record and what not to record. But in those cases, it's a tension between these principles, what they know is required for other people because it's relevant to the person's health, but what still seems extra emotional or sensitive. And in fact, that moral residue is kind of a good thing. It implies that a social worker is showing true respect to the client and really considering their point of view and their perspective on their own information. What we can hope is that the design of recording systems take into account the views of practitioners to ensure that ethical recording is not undermined. There are not necessarily simple answers to that. For example, it's not necessarily about enhancing restrictions on records, particularly if that puts a barrier up to sharing relevant information. So as well as the consultation of practitioners in forming recording systems, I suggest an intention to what would be considered trivial matters about how much information is required on a form and where that form lives is quite important. Also, I would think that professional education for practitioners to encourage them not only to record virtuously, but also in the way that they interpret records and they use records themselves. From what participants describe, the social work relationship has a central element of trust, as do most healthcare relationships. From the perspective of clients, social workers are the right people to be making decisions about what is and isn't necessary to record. They have the superior knowledge and experience about what information other professionals require. But social workers need to have a corresponding trust in the system to be comfortable taking on this trust of clients. So thank you for that. I'll give over to Katharine Wallis.
Thank you, Isobel. We must be just about running out of time, I think, aren't we? So I'll be very brief. So I'm Katharine Wallis. I teach the medical students in the Department of General Practice, and developed an interest in privacy when I did my Masters in Bioethics and Health Law down in Otago. It's a real privilege to be here, and I congratulate the Office of the Privacy Commissioner organising this day. And it's been lovely working with Isobel and Monique on this project, and one thing that's come through for me is just how every type of practitioner thinks they're the most special one to the client or the patient. Nurses think they see the patients the most, social workers think the information they're coming across is the most private. Doctors, we still think we're part of the team as well. I know pharmacists promote themselves as being, your leading health professional or whatever. So I think there's a real sense from all types of different practitioners that we all have a responsibility to patients and a real sense of trying to support a relationship that we have with our patients. I mean, as general practitioners, we deliver our service through a relationship, and confidentiality and our obligation to our patients is probably to us first and foremost and above the law. I know today's about the law, but when you talk to practitioners, it's largely their ethical obligations that they respond to more so than the law. And I do understand that we're all ignorant doctors and don't have much understanding about the law, but we do have that sense of trying to support a relationship based in trust, and that's what it's about. So I think the biggest threat to that sense of a trusting relationship that we try and form with our patients now is in general practice anyway, we don't always have that relational continuity, and we want to make up for that with some sort of informational continuity, and we have shared electronic records and everybody can read everybody else's, and we're trying to sort of keep up with who's doing what. But that does, the accessibility and the transmissibility of that electronic information does present problems, I think, for the relationship that we try and have, and that sort of implicit promise that we're giving to patients when they see us and they, unload all that sensitive information on us, without us perhaps even wanting it. Does create problems. Sometimes, patients will say, oh, look, they want to tell me all this stuff, but don't write it down. And so, and then if I don't write it down, not only do I not communicate that to myself, I might have forgotten by the next time I see them, it's also not communicated to anybody else. But they might be fearful that insurance agencies might get hold of the information or some other tension like that. So, patients might hold back, they might want us to hold back on recording. But also there's the threat with the electronic portals coming on board, I think, when people can dial in and access all the other types of providers. So usually when I would refer a patient to an orthopaedic surgeon for a hip replacement, for example, I don't need to tell them about how many terminations of pregnancies they've had, what their issues with, relationship difficulties are and things like that. But hospital people can now dial in and find, and access and read that kind of information. And, there is a tension there, and I don't think we've quite sort of sorted that one out yet. So I think that sort of brings back really what the purpose of the record is and who's it for. I mean, I certainly use it as an aid memoir. If someone comes in and says to me, oh, my daughter, who I might have delivered, is getting married in 6 months' time, and we have a nice chat about that, I will have forgotten that by the time they come back in 3 months' time for their repeat of their medication. So I'll write myself a wee note in the record saying, daughter getting married in 6 months' time or 3 months' time or next month or whatever it is. So when she comes back, I can say, how did it go? And that helps to, strengthen that relationship that you have with your patient. It's not important for accountability or anything else. I can see I'm getting the nod here. I'm talking too much, but we're open for questions.
Well,